We'll be discussing about ASCPi questions, ASCPi questions in hematology, especially in the second section of hematology, which we have already covered, and it's about RBC disorders or erythrocyte disorders. Of course, we will have some other disorders which affects erythrocytes in section 3. Of course, generally, some leukemias also affect erythrocyte lineage. For example, we have acute erythroleukemia, we have polycythemia vera, we have myeloproliferative neoplasms. Those one also affect red blood cell. So we will still have to talk about them, but those ones are mostly neoplastic disorders. So mostly what we have covered here in section 2, they are not neoplastic, but mostly are associated with anemias. We discussed iron restrictive anemias. It is not only about iron deficiency, it is about restriction. Iron is not used, whether it is deficiency, whether it is hemochromatosis, whether it is inflammatory conditions. We also talked about abnormalities of DNA synthesis, which is megaloblastic anemia. We talked about bone marrow failure syndromes like aplastic anemia, Fanconi anemia. We also discussed hemoglobinopathies, sickle cell disease, hemoglobin C, hemoglobin DG, and so. And we also talked about various hemolytic anemias, being intrinsic, being extrinsic, being immune, being non-immune, or inherited or acquired hemolytic anemias. We talked about all of these topics. Now, today we will be evaluating some questions about these topics in erythrocyte disorders. Before we can start, leukocyte disorders tomorrow. Okay. So these are the questions. The first question is saying hemolysis in paroxysmal nocturnal hemoglobinuria, which is known as PNH, is temperature dependent, complement dependent, antibody mediated, caused by red cell membrane defect. So what is associated with paroxysmal nocturnal hemoglobinuria? This condition was among hemolytic anemias. Yes, please. We'll do the same thing. You just type your answer in chat box, and we will be able to discuss, and we agree on one thing. Okay, let me check the chat box. I can see a DC. What about paroxysmal nocturnal hemoglobinuria? Is it antibody mediated? Is it complement mediated, temperature independent, and so? How does it look like? Yeah, we are having different answers. We have all the letters are selected. That is amazing. Temperature dependent, complement independent, antibody mediated. So who is answering the right thing? So that is, it is caused by red cell membrane defects. You remember we talked about the anti-complement factors, which is CD55 and the CD59 proteins, which are GPI connected. Yeah, so the GPI connected CD55 and CD59, and those are the membrane proteins of red blood cells. So because the membrane is defective, so the cell is now prone to hemolysis or antibody or complement mediated or complement dependent hemolysis. So when you choose letter B, you are choosing opposite, because it is not complement dependent, but it is complement dependent, because complement activation happens in case of the deficiency of CD55 and CD59. And temperature dependent is not correct, and antibody mediated is not correct, because not an antibody don't intervene in the paroxysmal nocturnal hemoglobinuria. Only complement cascades can be activated and hemolysis will take place. Okay, thank you so much. The second number, the question number 2. Now we have which of the following is mostly closely associated with idiopathic hemochromatosis? Idiopathic hemochromatosis. Iron overload in tissues, target cells, Cabot rings, ringed sideroblast. I think I will bring this particular abnormality of red blood cells like Cabot ring, and then maybe ring sideroblast. We have seen all of them, but which one is associated with idiopathic hemochromatosis? Idiopathic hemochromatosis. I can see A. Most of you guys are answering A, right? Yeah, we want everyone to participate, because this just comes once. Okay, the correct answer for A, as we said, for question 1 is D. This is because of membrane defects. So question 2, the answer is iron overload in tissues. Yes, that's correct. Iron overload in tissues is the one that associated with the hemochromatosis. Hemochromatosis would be the iron overload in tissues. Okay. Question number 3, the direct antiglobulin test can help distinguish. The direct antiglobulin test can help distinguish inherited from acquired, intravascular from extravascular, heterozygous from homozygous, thalassemia, sickle cell trait from sickle cell disease. Performing direct antiglobulin test will help distinguish what from what. Question number 3. Question number 3. Number 3, someone is answering. Number 3 is A, inherited from acquired cytosis. Let's see what other people say. My friend Innocent is saying A, is saying B, is answering B, intravascular and extravascular hemolysis. It makes sense as well. It makes sense. Yes, it makes sense. A, spherocytosis. A, B, yes. As you can see now, all your answers are make sense. Even B makes sense, makes a bit of sense, but A is the most correct one, because you remember that inherited spherocytosis, for example, we have seen spherocytes. We have seen the stomatocyte, like the inherited one, which associated with the membrane defects. That does not involve direct antiglobulin test. Yes, but for example, for the acquired spherocytosis, especially the immune, because acquired spherocytosis is mostly immune mediated. So immune mediated, it involves antibody, antibodies which targets RBC, especially the IgG. We can distinguish between the two, inherited and acquired, because inherited does not involve antibodies. So which means that in inherited, DAT will be negative, and acquired DAT is most likely positive. And intravascular and extravascular does not make sense, does not make enough sense, because it can be intravascular antibody mediated. It can be also extravascular, because sometimes when antibody can be able to activate complement, that is intravascular. It can happen intravascularly. And if antibody cannot be able to activate complement, it can only opsonize. It can be extravascular hemolysis. So we cannot use DIT to distinguish between intravascular and extravascular, but you can use it to distinguish between inherited from acquired spherocytosis. Thank you. So let's continue with the next. Question number 4. A 20-year-old woman with a sickle cell anemia whose the usual hemoglobin concentration is 8, develops fever, increased weakness, and malaise. The hemoglobin concentration is 4 now, and the reticulocyte count is now 0.1. The most likely explanation for the clinical picture is, given that this woman was having hemoglobin of 8. Now, after that, develops fever, and now the concentration is 4 with the reticulocyte count of 0.1, which means the reticulocyte count is very low. 0.1 is very low. Now, and you are asking, what is the explanation of this picture at this moment? Of course, given that even if you have a laboratory symptom, laboratory findings, we have also clinical finding, which is sickle cell, the mother with the sickle cell already confirmed. Huh? And what can that be? Increased hemolysis due to hypersplenism, aplastic crisis, thrombotic crisis, or occult blood loss. What can that be? Yes, we have AB. Please, Stephen, you are disturbing the screen. Please, try not to disturb, because here I'll be needing to clean. Okay. Yes, we are trying to answer question number 4. What is the cause of, what is the picture is this? Which picture is this? Someone with sickle cell, and now we are having the complications that hemoglobin now is 4, and the latest count is very low. What would be the problem here? And fever as well. Remember, there's also fever, and in sickle cell, fever is not typical unless there's something else that is happening. Okay. Now the answer is B. Okay, you're answering A. Some of you guys are answering A. Others are answering B, which is correct. B is the correct answer, because aplastic crisis is one of the complications of sickle cell anemia. Aplastic crisis. Sometimes there is a serious reduction or pause, especially for red blood cell. It can be usually pure RBC aplasia, or pure red blood cell aplasia. RBC will be reduced completely as a complication of sickle cell. And you can see that's why the reticulocyte count is also very low at 0.1, which is very low percentage of reticulocyte count, which shows aplastic crisis. Okay. Now we'll have question number 5. Question number 5, which says hypoproliferative red cell population in the bone marrow of uremic patients is caused by low, which means low RBC population in the bone marrow of uremic patient is caused by what problem here? If you remember, what we call hemolytic uremic syndrome, and of course uremic syndrome in general. What can that cause in order to result in hypoproliferation of RBC in the bone marrow? Question number 5. Let's go. Yeah, because we have 25 questions and we have to go fast. 25 questions, we have to use 50 minutes because in the ASCP exam, we don't use more than 1.5 minutes. We use 1.5 minutes to answer questions. Now we'll be using at least 2 minutes. Just look at it and think quickly, answer it quickly. Yes, and of course, we need everyone to participate. It is very important because when you answer a question and it is wrong or it is right, it can teach you something. BC, we have BC already. We have decreased level of circulating erythropoietin, defective globin synthesis. It's not that. So the answer is B, because in case of uremic patient or uremic syndrome, in most cases there is also a resultant renal problem or renal failure syndrome, especially in hemolytic uremic syndrome. The most significant issue here is the problem of renal failure. Decreased level of erythropoietin is the cause of hypoproliferation in the bone marrow, especially affecting red blood cells. So the answer for the question number 5 is B. Now we have also question number 6. Question number 6, which of the following characteristics are common in hereditary spherocytosis, hereditary erythrocytosis, hereditary stomatocytosis, and paroxysmal nocturnal hemoglobinuria? Which one is the common characteristic in those conditions? Yes, I'm dealing with our chat box. I'm checking for your answers. B, which means that most of you guys are answering B. Okay, why? Let me check why it is B. B is what? Red cell membrane defects. Yes, that's correct, because now we have spherocytosis, which is vertical defects, erythrocytosis, which is horizontal defects, stomatocytosis, which is a sodium potassium pump problem, which is of course cation problems, and paroxysmal nocturnal hemoglobinuria, which is CD55 and 59 problem. So all of those problems are red cell membrane defects. Okay, and that is the major characteristic which is common in all these conditions. Okay, the evidence that indicates, yes, for the question number 6 is B. Okay, B, red cell membrane defects. Now let's go to 7. Evidence indicates that the genetic defects in thalassemia is usually result in. Evidence indicates that the genetic defects in thalassemia usually result in. Yeah, we're talking about evidence. 30 seconds to think and 20 seconds to answer. Okay, let's go. 30 seconds already. Let's go. Number 7. Number 7, some people are saying B, others D. Alpha what? abnormality in alpha or beta chain binding affinity. Is it correct? Yeah, I know we do not discuss much on thalassemia yet, but I explained thalassemia when we were discussing hemoglobinopathies. And exactly, I brought this question because I know that I talked about it. Yes, this question number 7, the answer is B, quantitative deficiency in RNA resulting in a decreased globin chain production. So deficiency in RNA means what? It means there is also deficiency in DNA. So which means there is a problem somewhere in genome, in DNA. There is a problem of DNA or gene, which is also affecting messenger RNA production. And of course, you know, thalassemia is a quantitative defect or deficiency of gene. Okay, that is correct for number 7, which is option B. Okay. Now let's go to question number 8. Anemia secondary to uremia and chronic renal disease is characterized by what? Characteristically is. Oh, yes. I was reading it wrongly. Let me see what is the characteristic of anemia secondary to uremia and chronic renal disease. Renal disease, microcytic, hypochromic, hemolytic, pneumocytic, pneumochromic, macrocytic. Renal disease, anemia. B. Mr. Adam is answering a B. A B. Others C. Okay. For our 30 seconds to think, already elapsed. Now let's see what is the best answer here. When it comes to anemia secondary to uremia in chronic renal disease, and the problem now is not about deficiency of anything, for example, of iron. The problem here is reduced erythropoietin. Erythropoietin deficiency does not lead to microcytic or macrocytic or hemolytic. It leads to pneumocytic, pneumochromic, because there is only number, like reduction in number, but not in size or in shapes or in whatever thing. It is number of RBC are reduced. Okay, that is because of erythropoietin deficiency. Then the answer is C, which is pneumocytic pneumochromic anemia. Okay, question number 9. Which of the following set of laboratory findings is consistent with hemolytic anemia? Hemolytic anemia. Decreased bilirubin, the increased serum lactate dehydrogenase, decreased serum lactate dehydrogenase, and increased concentration of aptoglobulin and marked hemoglobinuria. Let's take 20 minutes to think, and we come up with the answer. Let's go. Which one here is a finding which is consistent with hemolytic anemia? Okay, let's go. Let's answer it. Let me check. Now I cannot. Then I won't be happy if all of you guys are answering it wrongly. Why? Why are you answering it wrongly, all of you? No one could answer it properly. Only maybe one person. 1 person or 2. No, don't be confused, my friends. Don't be confused. When we talk of hemolytic anemia, you cannot say that haptoglobin is high. It is not possible. Haptoglobin is always low, very low and we talked about it so many times that haptoglobin is always a low finding in hemolytic anemia because haptoglobin is a protein that is responsible for binding free hemoglobin in hemolytic anemia. And hemoglobin, when it is bound by haptoglobin, of course, haptoglobin concentration will be low in serum, and it cannot be D. It is not possible. So the answer is going to be B. Of course, there would be serum lactate dehydrogenase, which is high, LDH, and also increased catabolism of heme. Of course, as you remember, there is heme metabolism, which of course heme is going to be broken down, and it releases iron, because you know iron is bound on heme, and iron must be removed, and heme will be metabolized and become bilirubin, isn't it? So that's what will happen in hemolytic anemia. So question number 9 is B. It is not D. Please don't forget about haptoglobulin. Will reduce always in case of hemolytic anemia. Okay. Now, question number 10 is deficiency of this enzyme is associated with a moderate to severe hemolytic anemia after the patient is exposed to certain drugs and characterized by the red cell inclusions formed by denatured hemoglobin. Which one is that? Which one is said? Number 10, yes, number 10, please. Which one is said? Which one is said? Question number 10, we are talking about which enzyme that is associated with the hemolytic anemia, but also characterized by having inclusion bodies because of denatured hemoglobin. Inclusion body we are talking about here is Haynes body, because Haynes body is the one that are associated with the hemolysis of hemoglobin. I mean, sorry, denatured hemoglobin or oxidation of hemoglobin, Haynes body. Okay, let's now look at your answers. Oh, yes, now you got it right, all of you. You got it right. It is glucose 6-phosphate dehydrogenase. You know, glucose 6-phosphate dehydrogenase is a very important enzyme in hexose monophosphate pathway, and hexose monophosphate pathway is responsible for reduction of or removal of oxidizing agents, especially by using glutathione, which is reduced by NADPH generated through the activity of glucose 6-phosphate dehydrogenase. Of course, that is a HMP, hexose monophosphate pathway. So deficiency of this enzyme, hexose monophosphate pathway, will not take place, and there would be oxidation of hemoglobin, which is known as methemoglobin, and it will accumulate as inclusion body in red blood cell. Okay, now let's go to question number 11. Which of the following is the most characteristic finding in autoimmune hemolytic anemia? Autoimmune hemolytic anemia, which one is the most characteristic finding in there? Autoimmune hemolytic anemias. Okay, now I'm taking 20 seconds to think about the question, and then let's go with the answer straight. Question number 11. A characteristic of autoimmune hemolytic anemia. Autoimmune hemolytic anemia. Okay, let's look at your answer, and maybe we'll try to come up with the right one, the correct one. So because I see that you guys are having C, others D, which is not, cannot add as B. You know, you cannot have more than one answer. Okay, now the right answer is positive direct antiglobulin test. That is the right one. Let me check which answers we are also bringing here. Leukopenia and thrombocytopenia. No, it's not the case. It can come from something else. Leukopenia and thrombocytopenia. Let's see another thing. We're answering also peripheral spherocytosis. It is also a finding. It can be a finding. It can be one of the findings, peripheral spherocytosis. But the most important finding here is antiglobulin test positive, because autoimmune hemolytic anemia is associated with antibodies, and those antibodies mostly they are IgG, and they have already sensitized the RBC. So then direct antiglobulin test will be positive. Okay, now question number 12. Peripheral blood smears from patients with the untreated pernicious anemia are characterized by what? If someone is not treated for pernicious anemia, what will happen? Pernicious anemia, peripheral blood smears. Yeah, we need to have like different answers here so that we can agree on one. Someone is asking what's the question, what's the answer for question number 11? Number 11 is D, positive antiglobulin test. Now, question number 12 is what we are talking about now. Number 12, the answer is A. Yes, maybe some of you guys are choosing something else, maybe B or D, but the answer is A. Because when someone is having a pernicious anemia, pernicious anemia is a megaloblastic anemia, which is of course macrocytosis will be the finding, and also pancytopenia, because there would be, you remember, megaloblastic anemia is characterized by ineffective erythropoiesis. So which means that erythropoiesis is not taking place properly. So which means that even premature RBC will be hemorrhaged in plasma. I mean in a bone marrow. So the premature RBC will be destroyed, which may result in pancytopenia of the bone marrow. And also, leukocyte will also be affected, because especially in the case of lack of vitamin B12, even leukocyte will be affected in pernicious anemia, because pernicious anemia is about vitamin B12, and vitamin B12 is very essential for white blood cell development and even platelets. So in that case, of course, there would be pancytopenia. A, right? A. Okay, now we're on question number 13. 13, it's about, this is a long story, isn't it? This one is a long story, but let's see. Let's see what about it. Let's read it. Maybe we'll take 2 minutes to answer it. A 50-year-old patient is found to have the laboratory result shown in the table. Hemoglobin is low, hematocrit is low, RBC is low. If determined that the patient is suffering from pernicious anemia, right? Which of the set of the result most likely to have been obtained from the same patient? Okay, this patient was having low RBC indices, and the patient is diagnosed to have pernicious anemia. And what will be a set of result here? A, B, C, D. Check which one can be consistent with pernicious anemia among the 4 sets of results. Okay. Hey. Oh, you're answering the question. Yeah, yes. You're doing so fast. I appreciate. Okay. All right. All right. D. Oh, that one is good. That one is very good. Yes. Yes, you are correct. You are right, all of you. You are right. So what we yes, I'm really so happy so that you're now able to figure out what is happening now. What happens to this patient is that pernicious anemia is leading to pancytopenia, which is appearing on option D, pancytopenia, because you see what Barcel is low, 3.5 is low, platelet is also low, 80,000 is very low, and also the reticulocyte count is very low, which is 0.8. So this is a meaning of pancytopenia, reduced 3 cell lines, white blood cell, platelets, and RBC. Initially, of course, this person was having hemoglobin of 7 and RBC of 2, which means all the cells now are reduced, pancytopenia. Okay, thank you. Let's go to the next one. The next one, which of the following are found association with the megaloblastic anemia? Which one is associated with the megaloblastic anemia? This one is a very quick question. I think you will not think twice about it. You cannot think twice about this simple question. Megaloblastic anemia, which one is in association? Okay. Those one who are not thinking twice, they have already answered. But those one who are thinking twice, they are not answering yet. Okay, those one who are thinking once, the answer is A, neutropenia with thrombocytopenia. You remember neutropenia, of course, that is leukocyte count low. Thrombocytopenia is platelet count low, which is the typical finding in megaloblastic anemia associated with the pancytopenia. So what we could add here is also low hemoglobin or raw hematocrit or raw RBC, whichever thing you want. Okay, now question number 14 is A. 15 now, we have which of the follow, which of the result represent characteristic feature of iron metabolism in patient with anemia of chronic inflammation? Yeah, this is also a very common question in ASCPi. It's a very common question. Don't be surprised when you see you encounter a question like this in your exam. In ASCPi question, this is a very common question. Okay, we have which one can characterize anemia of chronic inflammation? And then I will show you which findings you have to base on without thinking a lot of things here. There are findings that don't change in anemia of chronic inflammation. And I think even Mr. Teza Brighton, is it? He's the one who was asking me this question on the phone today. And I think he's also here on board. And you are supposed to have answered it already, Teza. Teza from Zambia. I support to have already answered it. Because today we discussed about it and I explained to you how you can know that one. But I've not yet seen your answer here. Or you're not on board? Okay, everyone can answer it, and it's a very easy question. Let's see. CD, it is not possible to have many letters. We have A, B, C, D already, but the answer here is D. Yes, because this is anemia of chronic inflammation, which is characterized by low serum iron and low TIBC. Sometimes TIBC can be normal, but TIBC is usually low. In most cases, TIBC is low. Total iron binding capacity is the major finding here in chronic inflammation. It is low because the capacity or binding sites available for iron to bind is low. That is what the meaning. That's the meaning of TIBC. And also, transferrin saturation is low. One of the reasons is that saturation of transferrin is low, especially in serum, because transferrin is not binding, also is not transferring enough iron, of course, to the bone marrow because of some of the proteins. For example, hepcidin is an inhibitor. It stops the transport of iron, and also serum iron, of course, will be decreased. So that is those are the major findings in the anemia of chronic disease or chronic inflammation, which is usually characterized by decreased TIBC and low serum iron. So the answer for this question is D. Okay, now we have question number 16, which is about characteristic morphologic feature in hemoglobin C disease is which one? Hemoglobin C disease. And kindly, we have very interesting questions at the end of this presentation, maybe towards the end. Question number 20, 22, 23, 24, 25. They are very, very interesting questions. So don't miss them. Don't exit before we reach there. They are very interesting questions that you need to learn.
Number 7. Let's see.
The answer for the question number 16, we're talking about the characteristic morphologic feature in hemoglobin C disease. We also talked about it in class. Which one is that? One of the answer is yes. You are getting it right. The answer for 17.
So this question, that's what I always say. So this one like this. Patient has the resource.
Can you
Compatible with what? So there is microcytic, but MCV is low. MCH is low. This one common to the end, the lower end. There's microcytic chromic. So no.
Sorry, Mr. Adams, you're not yet there. We are still discussing question number 16, not yet on 17, right? So we are agreeing on 17 that this patient is having target cells, which is D, and that's what you selected, target cells, but also we have what we call hexagonal crystals. Hexagonal crystals is another finding in hemoglobin C. Yeah, hexagonal crystals, but target cell is also one of the findings. But target cell is not specific for hemoglobin C. It can also be found in sickle cell disease, but the specific one is hexagonal crystal. Okay, now we have question number 15 now, I mean 17. The patient has laboratory findings shown in this table. We have RBC low. No, not low. We have hemoglobin that so slightly low, that is hemoglobin. Hematocrit, MCV is low. MCHC is low, very low. MCHC is slightly low, not that not too low. And what is the, and which one is the result are compatible with the which condition here? Okay, question number 17. That's where we are. Yes, we are trying to assess or to evaluate these findings. Of RBC is a bit high. Hemoglobin is can say it is normal, but hematocrit is also normal. But MCV and FCH, they're not normal. And of course, when you look at these findings, when you look at these findings, you find that these findings are microcytic hypochromic, regardless of RBC count. Of course, we have microcytic hypochromic condition, and which that can be. We have some are answering A, others B, others C, but the answer is C. This is a thalassemia. This is a finding in thalassemia. Thalassemia is usually sometimes it is usually associated with high RBC count and with anemia. With anemia, especially the anemia is because this is thalassemia. It is quantitative reduction of hemoglobin concentration or hemoglobin concentration in each cell. Of course, the reason why hemoglobin is 13 looking normal is because of RBC count, which is high. But you can look at the MCH, which means concentration or amount. I mean, not concentration, but amount of hemoglobin in each red cell, which is low, 21, and also the concentration is also still low, 33. Okay, so and this is consistent with the thalassemia minor. It is not major because in major it will lead to serious hemoglobin reduction, which can be even less, up to 5 grams per deciliter. So the answer here is thalassemia minor, but it is not iron deficiency, it is not pregnancy, or it is not beta thalassemia major, because major one is serious, it's more serious than this result. So question number 18, we are having laboratory findings in hereditary spherocytosis include, lab findings in hereditary spherocytosis include what? Hereditary spherocytosis. Hereditary spherocytosis, we have which one? Decreased white blood cell, decreased RBC band 3 protein, reticulocytes, reticulocytopenia, positive direct anticoagulation test. Which one is in hereditary spherocytosis? Yeah, if you remember the defects in spherocytosis, the defect was transmembrane protein. Transmembrane protein, we have different, we have ankyrin, we have spectrin, alpha and beta spectrin, we have ankyrin, and we have band 3. So which means there is a problem in band 3 protein, because this is a transmembrane protein. Remember, spherocytosis is associated with hereditary, it's associated with the vertical interaction between transmembrane protein and underlying cytoskeleton protein. And one of them with the problems is band 3. Okay, Now the answer is decreased and a 3 in RBC, or a B. 19th question, we are now talking about 19 now. The characteristic morphological feature in lead poisoning is what? 19. Yeah, you are going faster than me, I can see. I'm trying to explain things and they are going faster than me. Now you are on 19 already answering it. It is a good thing. Now we agree that 19 is lead poisoning, macrocytosis, target cell, basophilic stipplings, and Lullock's formation. You're answering now. You're answering C, but I want to ask someone why lead poisoning is having problems on basophilic stippling, because this is the correct one, but why? Maybe now just choose someone randomly, or someone is going to open microphone and tell us why do we have problems with the basophilic stipplings in lead poisoning? How lead has anything to do with the basophilic stipplings? Lead poisoning? Who can answer? Who can tell us? Huh? No one? Or you just chose? Huh? Did you just choose? That is also acceptable in exam. If you know something, you cannot talk much about it. You can just still choose and continue. That's okay, as long as you know it is the correct one. But what is here is that basophilic staplings, they are RNA and ribosome accumulation in a cell, especially the maturing cell. So when someone is having lead poisoning, it will interfere with the enzyme, which is called RNase. Those RNase, ribonucleases enzymes, which destroy RNA and ribosomes. And of course, they're destroyed before a cell becomes mature cell. And so that the basophilia will disappear. So when the lead poisoning is there, the ribonucleases will be interfered by lead, and there will be persistent accumulation of RNA in the cell. That is what I wanted you to talk about. Okay, that is okay. As long as you know, lead poisoning can lead to basophilic stipplings. Now we have question number 20, which says the white cell feature most characteristic of the pernicious anemia is, which is the most common characteristic for white blood cell in pernicious anemia. Pernicious anemia. Pernicious anemia. Pernicious anemia. What happens in so pernicious anemia is of course the example of megaloblastic anemia, and what is there? Yeah, in general, the answer for question 20 is C. So in general, in pernicious anemia and generally megaloblastic anemia, hyperpigmentation is a key finding in white blood cell. Hyperpigmentation of neutrophil, sometimes you find 7 lobes or 6 lobes. That is a major finding in all megaloblastic conditions. Okay, C is correct. Huh? Question number 21, what is the most common mechanism resulting in hereditary stomatocytosis? What happens in hereditary stomatocytosis? I think I've talked about it so many times. Hereditary stomatocytosis, what happens? Abnormal NAK, deficient cytoskeleton, inability to repair, and depression of ATP. What is the major finding in hereditary stomatocytosis? Hereditary stomatocytosis. Hereditary stomatocytosis. What is happening there? Oh, oh, oh. Now I'm impressed. I'm impressed. I'm impressed. I'm convinced. Very convinced. Yes. Remember, this one is what you call overhydrated or dehydrated stomatocytosis. Overhydrated is potassium sodium pump is not working well, and sodium is entering, sodium is getting out, potassium is entering, and water is following sodium, and a cell will swell and become a stomatocyte. That is what happens in overhydrated, okay? And in dehydrated, there is a problem of potassium going out without being replaced by sodium, and water would follow, and the cell become dehydrated. So that is the two. Those are the two things, the two mechanisms in hereditary stomatocytosis. So it's a problem of sodium potassium pump. Okay, question number 21 is A. 22, individual with the Fanconi anemia characteristically show Fanconi anemia. Fanconi anemia, they show what? Fanconi anemia. We talked about Fanconi anemia in a plastic anemia, anemias. Aplastic anemia. Fanconi anemia is characterized by what? Still waiting for you. BBBBA. Oh. Oh my goodness. Who is answering B? Let me check this person. If this person attended the class. Oh, I'm not going to mention the name, but I see. I even see someone answering C. Oh my goodness. We are 22. Not 21, not 23. We're on 22. And why are you answering ring sideroblast? And why are you answering intravascular hemolysis? Intravascular hemolysis. I think I have to explain Fanconi anemia once again. Fanconi anemia is a plastic anemia, especially which is hereditary. Even if most aplastic anemias are acquired, but more than 70%, 80% are acquired, but a few of them are inherited. Fanconi anemia is one of them, and is the most common inherited aplastic anemia. And you know, in aplastic anemia, what you have, it is not hemolysis. It is like RBC are not synthesized, are not produced. And even, of course, sometimes almost every cell is not produced, which leads to pancytopenia. And it cannot be ring sideroblast because ring sideroblast is ring sideroblast isn't found in aplastic anemia, but which is associated with lead poisoning. It is not Fanconi. Fanconi anemia is different. It is inherited. So what is happening in aplastic anemia? I mean Fanconi anemia. It is increased hemoglobin F and erythropoietin, and also abnormalities in chromosome abnormalities, and also physical abnormalities, of course. Physical abnormalities, short stature, problems in development of the child, and so on. And skin dyspigmentation. Those are the findings in Fanconi anemia. But it is not ring sideroblast. This is a lead poisoning problem. Intravascular hemolysis does not happen in Fanconi anemia. Because why is it hemolysis? Why can't it take place? There's no There's no need of that. Then question number 23, hemoglobinopathy results from a fusion products of delta and beta gene is what? Delta and beta gene in hemoglobinopathies. What is which hemoglobin or which fusion hemoglobin is produced here? Hemoglobinopathy from fusion delta and beta gene. 23. 3. Okay, you are correct. You are correct. 23 is called hemoglobin lipol. Lipol is delta and beta, which is abnormal because delta and beta should not fuse because both of them are beta-like genes. So beta-like genes, it is like a duplication or hybridization. So they fuse and form abnormal hemoglobin called the lipol, which is very abnormal because delta should not fuse with the beta. Delta should fuse with the alpha or another alpha-like gene, but not beta. Okay, 23 is hemoglobin lipol variant or abnormal variant. 24, we have a medical technologist examining a peripheral blood smear and notice 7 large segmented neutrophil between 5 and 7 lobes. Everything else is okay, but 7 lobes, which other findings these lab technologists will find apart from 7 lobes, if any other thing is normal. Number 24. If any other thing is normal, what is going to be another finding for these people? I mean, for this, yes, 24. 24 can be challenging to you, right? Let me check, because I see you are answering different letters. Some are saying A, others B, others C, others D. Now we have large segmented neutrophil and many lobes, and CBC is normal. But which else could be abnormal here? Considering that this person is having 7 lobes. Okay. Now the answer is A. A is correct because apart from the lobes we are talking about, this person is having megaloblastic anemia, and of course you expect also high MCV, high MCH, and high RDW as well. So question number 25. Now we're talking about the statement about hemoglobin D and hemoglobin G. Which one is true? And which one is true for the statements about hemoglobin D and G? 25. Okay, 25. Question 25. Which one is true about hemoglobin D and G? They are typical something. Let me see. BBD here. Hemoglobin D, you remember that the other picture I brought when we are studying hemoglobinopathies, and you have seen where hemoglobin D and G are located, they usually migrate together with S on alkaline gel. So they can be separated. From S when you use acid pH or citrate electrophoresis. So the agar electrophoresis. So only, but when you use alkaline, so they will migrate together with S. So those one who are trying to answer question 25 for D, they cannot be separated by solubility testing. No, they can be separated very well because D and G are different. G is a alpha and D is beta variant. So they are different. And the beta one looks like S in solubility. So they are separated by solubility testing, but they migrate together with S on alkaline medium. Lastly, we have two last questions, the two ones, and let's finish with them. And then I will let you go. Someone is asking, please explain again. Answer 16. No. So sorry. Let's not go back. Let's finish this. Maybe you may check also our record because we are already recording. You can still use it. Maybe skip and reach 16 or 17. I mean 16 or 20. You will see our explanations. Let's continue with question 26. We're remaining with two questions and we want to answer them and we close. Refer to the following patterns. Pattern A, pattern B, pattern C, pattern D, and which pattern is consistent with the beta thalassemia measure? Yeah, you remember we talked about this pattern in class. How do we know this pattern is A, B, C, D? A, B, C, D. A, B, C, D. Which one is consistent with the beta thalassemia? Just think about it. Try to evaluate. Try to look into it. And remember, we are using cellulose acetate strip, which is alkaline electrophoresis. Alkaline electrophoresis. Mm. Hey. I think you are still thinking about it. Think quickly. Think quicker because you have 1 minute to answer it in the exam. Huh? Think quicker, right? At least you are trying. You're trying, huh? Solomon, George, have tried. I don't know if what you're answering is correct, but you have at least you have tried. Okay, let me also think. Just like 10 seconds. Let me check. We're talking about beta thalassemia, isn't it? Beta thalassemia major. Here is what? A, B. Okay. Got it. Okay, please. We need your input. We need your feedback first before we discuss this particular pattern. This is electrophoresis, which is performed on cellulose acetate strip or pH 8.4 alkaline pH. We have different hemoglobins here. We have alpha 2, we have S, we have F, we have alpha, not alpha, but A, A2, SF, and A. Okay, let's now evaluate the disease they are talking about, beta thalassemia major. In beta thalassemia major, it means that beta chain are not produced at all because it is homozygous major. Okay, so which means that this person is not able, this person may get very, very few, because thalassemia is quantitative. Does not mean there's zero beta. Maybe very few beta chains are there, so which cannot make enough hemoglobin A. So what will happen here, the person will have to show hemoglobin A, which is going to be very little, but there will be compensation, because compensation is happening in such a way that we don't need any other hemoglobin that requires B chain, which is F, hemoglobin F. Hemoglobin F does not require B chain, it requires A and alpha and gamma. So that will happen as a compensation. So which means that the pattern which is correct, which is consistent with the thalassemia major, is C, pattern C. Yes, pattern C, because we have small amount of A and big amount of F as a compensation. And we also have A2. A2 is also present because A2 does not require beta, but it requires alpha and delta. So that is consistent with the beta thalassemia major. So, but let's say that someone is answering a B. Let's start with someone who answered a B. Maybe someone also answered A. I think no one is answering A. Let's say if someone is answering, maybe let's say someone is answering a B. B, pattern B here, we have F, yes, that's correct. But you have also sickle cell. How can sickle cell associated with beta thalassemia? It's not possible. You see this pattern here. The big pattern here is sickle cell S, which is not correct for beta thalassemia, right? Then let's check if someone is choose to answer D. Answer D. D is, let's say D is this one, is A and A2. It is not possible because A you see here is so much here. You cannot say that this person is having beta thalassemia major with this amount of A. So which means that still beta is in high amount in the production. So we cannot, D is you can suspect it, but remember when we talk about beta thalassemia major, it involves compensation, and compensation always involves F and A2, but mostly it is F. So that is for beta thalassemia major because F does not require beta, and you know here there's no F at all, which is not possible for beta thalassemia major. Okay, that is what. So this is how you will be assessing this pattern, because it usually appears in exam, and you have to be able to assess it and answer question. It may look different, but that's how it looks like usually when it appears in exam. Oh. Okay. Yes, the last question is this one. The last question is question 27, and it is asking which electrophoresis pattern is consistent with the sickle cell trait. Sickle cell trait. Which one is consistent with the sickle cell trait, but not sickle cell disease? Sickle cell trait. Sickle cell trait. Answer for question 26, my friend, it is C, pattern C, okay? But we are now question 27, which is, we are asking what is now consistent with the sickle cell trait now on the other side. Sickle cell trait. Pattern A, pattern B, pattern C. Which one is best for sickle cell trait? Yes, A is correct. As you're answering A, you are very right. A is very correct, but not B, my friend. Who is answering B? A is correct, right? Because this one, we have it also in our notes, this pattern of sickle cell trait, where you know that in sickle cell trait, we have 60% of A, of hemoglobin A, which is this one, and 40% of hemoglobin S, and also maybe 5% of hemoglobin A2, which is also here. But we don't have F is like less than 1. It is very low. It is not appearing here. So that's why sickle cell trait is now consistent with the pattern A, because of both hemoglobin are present. Hemoglobin A is 60%, hemoglobin F, hemoglobin S is 40%, and then hemoglobin A2 is also present as in a small amount. But of course, as you can see, pattern B is not possible, because pattern B we have only F and S, and also A2. And pattern C is also not possible, because pattern C may look like the one for thalassemia, the one we saw. And then pattern D is not possible because we have A2 and A, but we don't have S. So because we don't have S, we cannot choose anywhere. So when it is sickle cell trait or anything sickle cell, we should check on S. S should be present. So it means you can choose between B and A, and then it is going to be A, because B is abundant. S is abundant, which is not possible for sickle cell trait. Okay. Thank you for your participation. I really appreciate. Yes. Okay. Let's go back to the questions you requested for the answers. Let's go to question 25 and see. Yes, question 25. We are talking about the statement which distinguish between D and G. So we have said that both of them migrate with S and migrate with this S hemoglobin in alkaline gel. And also, who is asked? Also, someone asked the questions. Who is this person? This person is Kanika Shalma. She asked about question 25. Let me check which answer is that. I mean 20 and 16. Yes, 20, pernicious anemia is characterized by hypersegmentation. That's for a C. And then we have also 16, which is this one. Feature of hemoglobin C is target cell. It is D. We have said it is target cell and hexagonal crystals. Thank you so much. I really appreciate you guys. Question 22. Question 22, let's check. Question 22, it is saying individual with Fanconi anemia, the major characteristic is A, which is hemoglobin F. Fetal hemoglobin is persistent. They are still young, actually. They are still young children, but still hemoglobin F, it is very, very persistent in those people. Thank you very much. Someone else also with their question, 20 and 20. Yes, Shalma. I've answered your questions. And thank you very much. And see you tomorrow as we continue with the next section in hematology. Thank you so much. God bless you.